Hello, everyone. Thank you for joining the Foundation for Peripheral Neuropathy today as we explore current and future treatment options for CIDP, which stands for Chronic Inflammatory Demyelinating Polyneuropathy. I am thrilled that we will be spending the next hour together on this topic and thank our generous sponsor, Johnson & Johnson, for making this program possible. My name is Lindsay Colbert, and I'm the Executive Director of the Foundation for Peripheral Neuropathy. On behalf of my team of staff and board members, I thank you for entrusting us with learning more about CIDP and participating in our educational programming opportunities. I wanted to let everyone know today that we are recording this program and it will be uploaded to our website in the next day or so for future reference. The slide deck that is accompanying the presentations will also be shared and uploaded to our website. For those that are joining us live today, we will have some time at the end of the presentation for questions, and those questions can be submitted through the questions box located on the dashboard of your platform. I ask that you please keep your questions on topic and general in nature. I'm also excited to share that we're providing closed captioning during today's program. This is a new feature that we were able to get, and we look forward to making it a standard across our webinars moving forward. And now I'm pleased to introduce two of our guest speakers today who will be presenting during the program. Dr. Vanessa Tiongson is a board-certified neurologist and assistant professor at Mount Sinai Hospital in New York. She practices general neurology but specializes in peripheral nerve, neuromuscular junction, and muscle disorders. She completed her neuromuscular medicine and EMG training at Montefiore Medical Center. Dr. Tiongson did her neurology residency at NYU, and she obtained her medical degree at SUNY downstate. She is trained to address a variety of neurological disorders, including but not limited to back pain, neck pain, peripheral neuropathy, nerve disorders, muscle disorders, headache, epilepsy, movement disorders, vascular disease, and multiple sclerosis. Dr. Tiongson is on the professional practice committee of the AANEM. Also joining today is Bob, a CIDP patient and friend of the Foundation's. He has faced CIDP since 2007. Despite challenges like foot drop, balance issues, and a 10% body impairment, Bob underwent IVIG treatment, 6 months of physical rehab, and continues to manage his condition with medications like Lyrica and regular neurologist visits. Bob is a retired attorney and former senior partner at a firm in Lewiston, Maine. With over 50 years of experience, Bob served as president of the Maine Trial Lawyers Association and vice president of the Maine Law Foundation. Despite his health struggles, Bob remains resilient and considers himself fortunate, recognizing others face even greater challenges. And with that, I'd like to pass the virtual microphone over to you, Bob, to get us started today. Thank you again for sharing your story with us. We're really excited to hear about it.
Thank you very much for having me. I wanted to tell the audience about my experience with CIDP. In 2007, I had a flu shot on October 9th, and 15 days later, I started to develop foot drop, inability to pick up my legs, neuromuscular pain in my lower extremities. I had a feeling like there was mud on the bottom of my feet. And when it got to the point where I couldn't walk, I went to the ED in Santa Barbara, California. And luckily, I had a emergency room doctor who had seen several cases of Guillain-Barré. And to confirm it, he brought in a neurologist who did a spinal tap and admitted me to the hospital. At the time, the treatment was IVIG, which is intravenous immunoglobulin, and it had to be given at the same time every day while I was in the hospital. So I would get up at 3:30 in the morning when they would give me the IVIG treatment. I was in the hospital for 5 days. I had to learn to walk again and go up and down stairs. I was prescribed physical therapy, occupational therapy, and pain control. And I had to learn to live with the fact that I still had foot drop, which meant I couldn't pick up my foot and walk by myself. So I had to use either a walker or a cane. At the time of my discharge, I was shown how to do exercises at home. And when I returned to Maine in early November, I did two things. I had a wonderful physical therapist in Maine, saw him 3 days a week. He gave me exercises to do at home I did those for 7 days a week, and he had a saltwater pool, which I use 5 days a week. And the pool does two things. It increases your buoyancy, so you're able to do more things. And the salt water in the pool, chemical salt water, helps when you were doing exercises. So I would do heel raises, toe raisers. I would walk up and down the pool on my heel, on my toes. I would use styrofoam spaghetti toys to kick my feet back and forth. And I did that for about 6 months. One of the things I had to relearn was my ability to cognitively know where I was going if, for instance, it was a dark room. So the therapist had me walking up and down a hall with no lights on backwards. And by doing that, I was able to increase my ability to know where I was and to get my brain and my feet back in synchronicity. I also continued to see the doctors. I had a neurologist in Maine. He was continuing to treat me with a drug called Lyrica, which I still take 17 years later. I had problems with my gait. I would shuffle. I had bilateral foot drop. I had a repeat EMG, which is an electromyograph, which is not a pleasant thing, where they measure the resistance in your nerves and to see if there's any change in your treatment or in my exercise. My final diagnosis was Guillain-Barré syndrome with CIDP, and they were able to clinically and medically correlate the fact that it was from a flu shot. I had taken flu shots for 35 years and never had a problem. I guess this particular batch, which was and is egg-based, triggered the reaction in me. 1 in 250 to 300,000 people get the reaction. When the drug was developed in the late 80s, the drug companies made the government make them immune from suit for people who got sick. And although the drug companies deny the fact that there's a correlation, there is a correlation. So I was one of the unfortunate ones that just happened to get it because of the shot. I can't take flu shots anymore, and I can't take shots for shingles or anything else that would require an egg-based kind of vaccine or treatment. At the present time, I've learned to live with the results of the CIDP. Over the years, I've had several more EMG tests. I have to be careful because of balance. I had a balance problem immediately when I was diagnosed, and I still have the balance problem, and it's getting worse. I don't have any significant ankle jerks, which means if they hit me on the side of my ankle, I won't get a reaction, or the doctor won't get a reaction. And the pattern of my nerves is not great, because if they use a tuning fork or a pin to trace the nerve patterns in my foot, I would say about 90% of the time I don't have any reaction. And sometimes on the lateral aspect of my legs, I don't get any reaction either till they get to the knee. I continue to do physical therapy by going to the gym and working out with a trainer, and doing things like going up and down stairs, doing squats, doing jump ups, anything that will try to get my brain to correlate with the rest of my body. I do have pain in my lower extremities, and that's transient or comes and goes, not always the same time. I've also developed a sensation on the top of my feet and sometimes the bottom of my feet of extreme itching. It's called pruritus. And so I take a drug called nortriptyline at night to help reduce that. And that is also as a result of the CIDP. I've tried different drugs in different combinations, like Neurontin, and some other drugs to minimize the interference with the transmission in the nerves. I'm pretty much on Lyrica now, and I can't take the generic equivalent, which is called pregabalin, because the generic just doesn't work for me. And so I have to use the brand name, and that's kind of expensive. It's a couple $100 a month. And that's after insurance pays for their part. Also, at the present time, I face increased fatigue during the day. I have to be careful going up and down stairs. I have to be careful of turning quickly because of balance problems. And I have to be careful of walking on uneven surfaces because I can lose my balance easily. The disease has progressed slowly, and there's no magic bullet to cure it. I see the neurologist twice a year, and she goes through all the testing that we've talked about. There are some alternatives for CIDP treatments, but one of the problems is I had at the time, and I still have it, I have a disease which is also an autoimmune disease called Crohn's colitis. And there are several drugs that are biologic drugs that would help me with my Crohn's colitis, but I can't take them because 10% of the people who take biologics have a reoccurrence of Crohn's disease. So it's kind of a catch-22 situation. You can live with the disease. You can work around the constrictions of daily living and the problems with walking, balance, fatigue, and that kind of thing. But it's something that you just eventually learn to live with and accept. I was very fortunate to have great doctors and physical therapists help me out. One of the things that you have to be careful about is using medication that can make you drowsy. One of the problems I had with Neurontin was it made me very drowsy in the afternoon. I've also tried using orthotics in my shoes and my sneakers, and that helps sometimes and doesn't help sometimes. So basically, after 17 years, I'm doing pretty good. I can live with it. You can't cure it, but you can certainly be productive and not let it bother you. Thank you.
Bob, thank you so very much for sharing your story. We really appreciate it. And for those that are watching live, if you have any thoughts or questions for Bob, please feel free to include those in the questions box, and we'll be sure to invite him back at the end of the session so that you can have an opportunity to chat more with him. And now at this time, Bob, thank you again. I'm pleased to welcome Dr. Tiongson to start her presentation on New Horizons in CIDP. Thank you so much.
Hello, I'm Dr. Tiongson. Thank you again, Bob, for sharing all of that, and thank you, Lindsay, for the introduction. I'm excited today to talk to you more about New Horizons in CIDP. I'm going to talk a little bit about what CIDP is, as well as the current and future treatments. I did want to give some disclosures. I have participated in paid advisory panels in the past for argenx and Johnson & Johnson. Those were specifically in regards to medications for myasthenia gravis, and although none of them are, some of them are indicated for CIDP now, and possibly in the future, I did not actually participate in ad boards for CIDP. So during this talk, I'm going to talk a little bit about what CIDP is, what are its signs and symptoms, how we diagnose it, what therapies are available, what are their pros and cons. I'm going to talk about some of the older therapies in quite a bit of a detail, and then some of the newer therapies and some of the things that are in pipeline. I'll talk about some of their pros and cons, and we'll go from there. So CIDP, it stands for chronic inflammatory demyelinating. Sometimes you'll see polyneuropathy, or sometimes you'll see polyradiculoneuropathy, and I'll go into a little bit of the detail about what that means in a second. It's pretty rare, about 83.9 people per 100,000 people are affected. It's more common in males than females. It's more commonly diagnosed between the ages of 50 and 60, but certainly there are other ages that can present with it. So, the name CIDP, so chronic, basically means that it's somewhat of a long-standing disease. Inflammatory is a terminology that we commonly use for something autoimmune. So it's an autoimmune disease, which basically means it's a disease where the body's immune system attacks itself. And then demyelinating means that it affects the myelin. So in the case of CIDP, what happens is that the immune system is attacking the myelin. So what is myelin exactly? So I have a picture of a cell over here. I don't know if you can see the arrow, but the dendrites are what receive the signal. The nucleus is kind of the center, and then the axon is what sends signals out to other cells. So around that axon, the messenger, there's myelin, and myelin helps speed up transmission of signals. And so in CIDP, that myelin is getting damaged by the immune system. And then the last part of it, polyradiculoneuropathy, means that it's a disease that affects multiple nerve roots and nerves. And this is really going to be the peripheral nervous system, not the central nervous system, which includes the brain and spinal cord. CIDP, I think that we are continuing to learn more about what CIDP really means. At the moment, there's a lot of characteristics, there's a lot of variability of presentation. So, as time goes on, it's possible that we might be able to delineate more of the details about different types of CIDP and which ones might be able to respond more to one treatment, instead of another. But we're not quite there yet. So for the time being, we kind of refer to it as more of a syndrome. It's a little slow to respond. Okay, so now I'm going to just talk about some of the signs and symptoms of CIDP. So Bob talked about a lot of these. There's weakness of the limbs, so this can affect, your upper arm and lower arm, your upper leg, your lower leg, causes numbness and tingling. So that could be decreased sensation to temperature, but it can also be decreased sensation to where your body is in space. So because of those two characteristics of weakness and numbness, you will often see balance impairment, as Bob described. And that's usually due to a combination of, decreased strength in your legs, but it's also due to kind of a decreased awareness of where your body is in space. In addition to that, neuropathic pain is a common symptom. It tends to occur, both in the hands and the feet. This pain can be described as burning or itching or tingling or discomfort, but it is a major symptom of the disease. And I didn't put this in, but fatigue is also a common complaint as well. So there's definitely a lot of variation in the presentation of CIDP. There's classical CIDP, which affects both the upper and lower arms and legs and is more symmetric. There are multiple variants of CIDP. There's the multifocal version where one limb might be affected more than another limb. One nerve might be affected more than another nerve. In the focal distribution, it could be just one limb is affected. There's also a distal predominant one, and then there's also pure motor and pure sensory variants. So just like there's presentation, variations in the presentation of where you have the symptoms, there's also variations in the presentation in terms of timing. It seems that Bob had a pretty acute presentation of the disease, after his flu shot. Probably that's why he got first diagnosed with Guillain-Barré syndrome, which is also known as AIDP, which is acute inflammatory demyelinating polyneuropathy. So what distinguishes CIDP is that it's going to be going on for longer than 8 weeks. You're not going to see it as great of a recovery. And then, Guillain-Barré syndrome has a higher rate of facial involvement and also breathing and issues with blood pressure and heart rate. Could be more of a relapsing remitting course where you have better periods as well as exacerbations, and then there could also be more of a progressive course where things slowly get worse over time. So CIDP is a pretty challenging diagnosis to make. Like Bob had experienced, there's an extensive, history and neurological exam where we really look at the strength of the muscles. Are you numb to pinprick? Are you numb to vibration with the tuning fork? What are your reflexes like? So usually we'll see, decreased sensation to the vibration, which is a measure of how your body is able to tell where it is in space. You'll often see absent reflexes, particularly in the ankles. Over time, you might have some changes in the anatomy. In chronic neuropathy, like high arches or hammer toes. A lot of these findings, they suggest neuropathy, but they're not necessarily specific to CIDP. So if you are then concerned about neuropathy, usually the most important test you do is the EMG. So EMG stands for electromyography. So a lot of people are familiar with the EKG that looks at the electrical activity of the heart. The EMG looks at the electrical activity of the muscles, and the nerve conduction studies looks at the electrical activity of the nerves. I'm not going to go into all of the details of what the test entails. It involves some electrical stimulations and some needles, and it's not a particularly comfortable test. The European Academy of Neurology and the Peripheral Nerve Society have created a pretty specific criteria about how to define CIDP. Despite this, it's still somewhat challenging to definitively say it's CIDP based on the EMG. Based on the criteria, you can categorize someone as CIDP or possible CIDP. And then if you have possible CIDP, there's some additional testing that you might be considered for. More recently, imaging studies have become more important in CIDP. Nerve studies, nerves in general, when there's something wrong with them, they can become enlarged. And in CIDP, you'll see kind of a non-uniform enlargement of nerves. So some, the ultrasound can potentially show, for example, enlargement of the nerves in the brachial plexus, or nerves that shouldn't be enlarged. Like sometimes you might see enlargement in your carpal tunnel because of carpal tunnel syndrome, but if you're seeing it in areas that don't get compressed very much, this might raise a red flag for CIDP. In this particular image, I don't know if you can see, E shows like an enlarged brachial plexus and F shows a normal one, and then the rest of them are just enlarged nerves. An MRI can also be useful in the diagnosis of CIDP because you can see enlargement of the nerve roots as well as enhancement. The MRIs can be done pretty easily, but the ultrasounds do have to be done by specialists most of the time. It tends to be done more often by neuromuscular specialists, but some radiologists can potentially do it as well. So some other testing that might be considered, the blood tests can help further delineate like perhaps what type of CIDP you have, and it can also rule out some other diagnoses. Spinal fluid testing might also be considered, which is basically a spinal tap. There's a certain finding where you have high protein but normal white cells, and that's kind of the characteristic finding of CIDP. However, it's not specific for CIDP. It can also be seen in things like, lumbar stenosis or diabetes. If someone is still unsure and really wants more definitive testing, sometimes a nerve biopsy is considered, but they do take a section of your sural nerve or whatever nerve they test, and that can result in some degree of permanent numbness. But you also need a good pathologist to look at the slides for the nerve in order to get a good diagnosis. It's not uncommon for people to really just go to, response to treatment in terms of trying to diagnose CIDP and giving something like IVIG or steroids. This is just I just named a bunch of things that are potentially in the differential diagnosis for CIDP. I'm not going to talk about them in detail, but just be a little sympathetic to your doctor because there's probably a lot of things going through their minds about what could potentially be going on with you. So now I was going to talk a little bit about the different treatment modalities. So the first line treatments have not exactly changed. There's still corticosteroids and IVIG, also known as intravenous immunoglobulins. I was going to first talk about steroids, which are probably the first things used for CIDP when it was found. So steroids, they're immunosuppressants. It improves symptoms in the majority of CIDP patients, and for some patients it can result in remission, which basically means that they don't have symptoms or worsening of their symptoms despite no treatment. It's relatively convenient to use. It can be used as a daily pill and then started on a high dose and then tapered. It can be done monthly as an IV medication. It can also be done monthly as an oral medication. And then you might consider, reducing the dose if the symptoms are stable. Unfortunately, steroids have a lot of downsides. It's not effective for pure motor CIDP. It has a lot of short-term side effects. It can make you rather agitated. It can elevate your blood pressure, your sugar. It can irritate your stomach and make you more prone to acid reflux and ulcers. Can cause some swellings long-term. It can result in diabetes, weight gain, kind of changes in your anatomy, such as kind of rounding of your face and kind of a hump on your neck. It can also cause some bone loss, increase your risk of vision issues, and increase your risk of infection. So, in general, the higher the dose, the more problematic it is. So if we have patients on steroids, we try to reduce the dose as much as possible. And, usually if you can put them on a low dose, you can maintain patients better that way. now I'm going to talk a little bit about what Bob had received. It's called intravenous immunoglobulins, also known as IVIG. It's made from the plasma from blood donations. It's an immunomodulator. Its mechanism isn't fully understood, but has a role in, IgG, which is part of our immune mechanisms. So how does, what is the normal course of getting IVIG? Usually there's an induction and then there's a maintenance. So usually the induction is a higher dose. It's double the dose of the maintenance dose. Usually the first treatment occurs over the course of, 2 to 5 days, and each infusion is around 4 hours long. Usually patients are then started on maintenance, which is usually every 3 to 4 weeks. And then, this can be received at home or in an infusion center. And then, if the patient is doing well, you can increase the interval to like 6 weeks. If the patient isn't doing so well, you might shorten the interval to, closer to 2 weeks. After, if you have several cycles and there's really no response, 3 to 5 cycles, you would call it treatment failure. This could potentially have a high cost depending on insurance. It's certainly a high cost to the insurance itself. So, I'm going to talk about side effects in a second. I will say that most people do tolerate it pretty well. But then the side effects can be a little bit scary when you look at them. There's a risk of allergic reactions, and these can be potentially serious allergic reactions. There's a risk of blood clots, whether that's, a blood clot in your leg or lung, heart or brain. That being said, I honestly haven't had, many patients, if any, have blood clots as a consequence of it, but it is a known risk factor for sure. I think the most common side effects that I really do see are more the headaches and the flu-like symptoms. It definitely does cause a lot of malaise. There's also a risk of kidney issues. So, when you're considering candidates for this medication, you really don't want patients who have a significant history of blood clots, heart disease, or heart failure, or heart disease or heart failure, or kidney disease for this treatment. There is an alternative. So like say you start on IVIG treatment, you can be switched to what's known as subcutaneous immunoglobulins. So this is pretty much the same as the IV version. It's just that you administer it to yourself. So you don't have to necessarily work around a nurse or an infusion center. You do it at home. They give you various devices that they try to make fairly easy to use. Usually there's a bunch of them that a majority of them are given on a weekly basis, but there is a new medication that is now every 4 weeks. And basically you do have to do multiple injections once a week. So it is definitely more frequent dosing. The side effects are pretty similar to regular IVIG, with the addition of some local side effects of like pain and swelling. So you would use this potentially for maintenance, but not for initiation. This is kind of a side note. Like there's a lot of companies have made a lot of brands. There's a reason you can't see them all because I didn't really want to talk about all of the details. There's a lot of brands of both subcutaneous and intravenous immunoglobulins. So how do you choose? Honestly, there's not really a difference in how well they work reported. In terms of like timing, the high QVIA is the only one that's now available as a subcutaneous 4 weeks. The rest of them are all kind of the same. There's definitely some variations in insurance coverage. So some insurance might approve one but not the other. I don't think it really makes too much of a difference. There might be some variations in the side effects. And there's also some variations in their actual indications. Like some of them are not officially indicated for CIDP. Some of them are indicated for inflammatory neuropathy. They're all kind of the same though. So, when you're first deciding your first treatment, usually this decision is between immunoglobulins versus steroids. There's some studies indicating that pulse steroids have a longer duration of like remission where you don't need additional treatment for a while. So that would be the only reason to really tolerate the steroids. IVIG might work a little bit faster and have better adherence. There's really a worse side effect profile overall with the steroids. Steroids you probably want to avoid in patients who have diabetes, and caution patients who have significant bone disease like osteoporosis. And then, like I mentioned earlier, the immunoglobulins you really want to avoid in patients with heart failure and blood clots and kidney disease. So after, IVIG and steroids, what has been a mainstay of treatment is something known as plasmapheresis. What is this process? Basically, it's filtering the plasma part of the blood and replacing it with saline and albumin. So the plasma contains a lot of the antibodies of the immune system, so it's kind of filtering out your blood of some of these immune particles. This often requires you to have kind of a long-term intravenous access. So this could be like a port, which can kind of be annoying to have because you often need to protect that port from infection, and it kind of like is in the way. Also, plasmapheresis can't be done at home because it needs a specialized machine. So it has to be done at a center or a hospital. So usually it's 5 exchanges over 2 weeks, and you might do this every so often, for example, every couple of months or something. So it can cause some drops in blood pressure, some risk of infection, changes in electrolytes, and, kind of feeling cold and having a low body temperature. But it can be effective in some patients who don't respond to IVIG and steroids. So I was going to talk now about some of this is basically the new FDA-approved medication for CIDP. So this was approved just this year in June of 2024. So this medication was originally approved as the IV version in 2021 for myasthenia gravis, and then the subcutaneous form was approved in June 2023 for myasthenia gravis, which is just another kind of a neurological autoimmune disease. So for CIDP, only the Vyvgart Hytrula, which is the subcutaneous version, is approved. So what does this medication do? So what it does, there's this peptide known as FcRn. So when immunoglobulins bind FcRn, they get recycled back into the bloodstream. What this fragment does is it blocks the FcRn, so it leaves our regular IgG floating, and when it's left floating, it gets destroyed in the cell. So basically, across the board, it lowers the level of IgG by about 60 to 70%. So you still have 40% in your body, but you reduce kind of that immune reaction that your body is having. The trial, it's a little bit complicated. So first they had patients who were diagnosed with CIDP based on various criteria. They were told for 12 weeks not to have any therapy. And then after that, they were given Vyvgart, and then 66.5% had a response. Then all the patients who had a response, they were divided into 2 groups. The placebo versus the Vyvgart group, and then they measured, time to relapse. So this really works for more of like a relapsing remitting type CIDP in theory, but there was definitely, a greater rate, probably about double a rate of relapse in patients who got placebo versus Vyvgart. So how is it administered? This is a weekly subcutaneous injection. It has to be administered by a healthcare professional, so usually that's a nurse. The injection is pretty short though. It's about, they say 90 seconds. It probably is more like 5 minutes or so. So the side effects are headaches. There is increased risk of upper respiratory infections and urinary tract infections, although in the trial I believe it's you get similar numbers for both. There's a possibility of allergic reactions. I forgot to put this in there, but there also was some decreases in the white blood cell counts, but it was not really enough to discontinue drug. One thing to note was that it was pretty well tolerated medication. 99% of the patients who were in the trial opted to continue the drug when the open label study started. Some other known treatments are kind of more of your classic immunosuppressants. So a lot of these immunosuppressants are used for a variety of different diseases. So some common ones are azathioprine, Cellcept, and cyclosporin. These are kind of like our not as extreme immunosuppressants, like they increase your risk of infection. Other things that they might increase your risk of are like liver damage or changes in your blood counts. So when you're on these medications, you have to be monitored regularly for your blood counts and your liver function. There's not really that much evidence, unfortunately, that they work that well, but you'll often see patients who have CIDP on these types of drugs. If the patients are refractory, they might be considered for some of these other drugs like Cytoxan, Rituxan, or even some of these repurposed MS medications. These are kind of stronger immunosuppressants that are often targeting like B cell pathways or T cell pathways. For example, Rituxan basically eliminates all the B cells. So with these drugs, they are like Cytoxan and Rituxan are probably widely accepted to be effective, but they can have some pretty toxic results, side effects like, multi-drug resistant pneumonias with multifocal pneumonias. So, they are stronger immunosuppressants, but sometimes they can be quite effective. Bob also talked about, some of the neuropathic pain medication. These pain medications, they don't improve nerve function. They're really for treating the pain, like the pins and needles, the tingling, the burning, the itching, those types of pains. A majority of them, like he said, can make you sleepy. So both gabapentin, also known as Neurontin, pregabalin, Lyrica, those tend to make you sleepier. And then there's some other drugs that can also help. He had mentioned nortriptyline, which is a type of antidepressant, and then also duloxetine and venlafaxine can also help with nerve pain. And this is also another type of antidepressant. I also wanted to just talk about some of the medications that are in pipeline for CIDP. So one of them is known as riliprubart. I don't even know if I'm pronouncing this right, but so this is in a phase 2 trial with Sanofi. This one is a different mechanism from the one that I discussed, which was Vyvgart. This blocks a different part of the immune system called the complement pathway. They would, and this would be, if this got approved, the way they want it to, it would be an every 2 week subcutaneous injection. They had looked at this medication in 3 different types of patients, ones who had failed standard of care, ones that had an inadequate response to standard of care, and ones that were entirely treatment naive. And they said that they had a significant response across all cohorts. They said that 88% were stable to improved. In one, I can't read what I wrote there, but I think that might have been the one of the standard of care groups of patients, maybe, and then the other standard of care, I can't remember if it was failed versus inadequate response, but these are patients who previously received standard of care. So 50% were improved. So I think they are recruiting for the phase 3 trial at this point. This is kind of a side note, but there are other complement inhibitors that are on market for myasthenia gravis that they target one part of this of the complement pathway. Unfortunately, that part of the complement pathway increases the risk of meningitis. This drug, they're hoping, will not have that on the labeling because it's targeting a slightly different part of the pathway. There's a few other, this is not a comprehensive list of all the medications in pipeline. There's other FcRn medications, including nipocalimab. What's nice about this is in phase 3 trials, and then it might be approved for myasthenia gravis in the next year or two. It doesn't cross the placenta, so it might be a potential option for patients who are female and of childbearing age. We don't have as much information about any of the other drugs at the moment. There's also a couple of other medications, rozanolixizumab, which is currently approved for myasthenia gravis as well. And then there's this other drug, batoclimab, which is also being studied for both CIDP and myasthenia gravis. There's another drug called Demyelinating, I can't even pronounce that, that is targeting some retroviral envelope. And, they've had this is not in trials yet, but they did find this viral envelope in Schwann cells in patients who have CIDP, so it's going to be interesting what they do with that. And then they're also probably going to look into some of the medications that treat MS, multiple sclerosis, which is another autoimmune neurological disease. So in summary, CIDP is an autoimmune condition that attacks the myelin of our nerves. We're still learning about the disease more and have a lot more to learn. Symptoms include weakness, numbness, nerve pain, and balance impairment. It's a challenging diagnosis with many potential modalities to diagnose it. The mainstays of treatment are steroids and IVIG. There's pros and cons to each of them. Plasmapheresis is another option. Vyvgart Hytrulo is the newest option, and then there are several drugs in pipeline that they're looking into. But it's exciting right now for CIDP because the first drug has been approved, and people are really looking into CIDP and looking for options which might not have been the case in the past. So I look forward to hearing questions. Thank you.
Thank you so much, Dr. Tiongson. And again, Bob, thank you for your previous story. We do have a lot of questions that came in, so I want to take the next 10 or so minutes to talk about that. So Bob, the first question goes to you. Folks are curious how you were determining which drugs worked for you. You went on IVIG, you tried Lyrica, you tried pregabalin. So how did you come to a treatment plan that has been able to give you relief?
Well, basically, it's a matter of trial and error because this is a chronic disease, and so we tried some things. I tried corticosteroids for a while. I always went back to the Lyrica. The only thing that's changed in the last 4 or 5 years is the doses are increased because of increased episodes of pain. But basically, it took me 3 or 4 years of trial and error to come to a treatment program as far as medication.
And my assumption is you worked directly with your neurologist on that, or did you have a whole care team that you worked with?
Basically, a neurologist who was familiar with CIDP. Initially, I was going every 3 months. Now I go every 6 months. But it was basically with a doctor who was familiar with the symptoms.
Great. Thank you. Dr. Tiongson, this question is for you. So a patient writes that, CIDP damages the myelin, and it's often said that the immune system attacks the peripheral nervous system. Curious, what exactly in the immune system is it attacking?
So, I mean, it's, sorry, you're asking what is the immune system attacking, or?
Yeah, yes. If it's attacking the peripheral nerve system and that's why some of the damages are being caused, curious why that attack is happening and why the failure in the peripheral nervous system is occurring as a symptom.
So, the immune system is meant to, attack infections and foreign substances, things that it doesn't like. It could be activated by things like infection or, exposure to something that it considers foreign. Um, and then in that process of activating that immune system, it can potentially, see targets related to what it's been activated to attack in our nerves. So it can potentially attack that myelin, and when the myelin gets damaged, you lose that covering of that axon, and then the nerve gets very, very slow. When the nerve gets very slow, it can result in, that loss of sensation, that loss of strength, because that nerve is feeding into the muscles, it's feeding into the skin. And if those signals are not getting through, then is what results in the symptoms. I hope that answers the question.
Yeah, I think it does. Thank you so much. Um, so this is a question. I'm really not sure if you're going to be able to answer this, Dr. Tiongson, but I figured I'd ask because there are lots of people asking about insurance companies. So why aren't they paying through even if some of these drugs are FDA approved? Like, do you have any sense in your practice why some drugs are covered and others aren't, or treatments, for example?
In terms of like um, the insurance and the variations and the different kinds of IVIG and subcutaneous options of immunoglobulins. A lot of times the insurance will have their preferred drug, and why that's their preferred drug, I'm not exactly sure.
Right.
It probably doesn't make too much of a difference in terms of like which IVIG company. These newer drugs, well, the new drug, Vyvgart, it's certainly very expensive. Um, the insurance might have like criteria that you need to try certain things before you can get covered for Vyvgart, and they might eventually actually, I don't know that they all have clauses where they say they won't cover it. It's just that you might not need to go through a process before they do agree to cover it.
Yeah.
And then, a lot of times what I found that the insurance companies, the people who approve the medications, they don't actually know very much about CIDP. So I've gotten one rejection, I remember, where they're like, you should try this drug instead. And it was a drug that wasn't approved for CIDP at all. And
Right.
it was, so it can be a very frustrating process, and it does require, the doctor might be able to advocate for it, but it's a lot more effort on our part.
Understood. Understood. Bob, curious, are you on a special diet that you found to be really helpful to manage some of the symptoms you have from CIDP?
Well, because I also have Crohn's disease, which is an autoimmune disease, I have to be careful about certain kinds of vegetables. Um, but there's no magic bullet. You kind of have to um, just find your space. There are cookbooks that you can
Hmm.
get. I think you may have them in your office. There are monographs about different kinds of foods. And just to follow up with Dr. Tiongson, when I faced a problem with the insurance companies, who are basically dummies, I always got my doctor to advocate for me. And I was on the phone, and you really got to push, and you have to say, this drug won't work, or this drug is not something that I recommend to try in this patient, and I won't do it. She needs or he needs this drug. And usually they back off. But like with IVIG, the cost in 17 years ago when I first had it was $25,000 a dose. And I had a fight with them from
Yeah,
a hospital bed, but they backed down.
good. Well, that's good to hear. Um, Curious, Dr. Chungson, you mentioned a lot of treatments during your presentation that are specific for CIDP. as you can appreciate, because we're the Foundation for Peripheral Neuropathy and we have other viewers that don't only have CIDP joining us today, do you find that a lot of these treatments are also good for other forms of neuropathy, or is this primarily specific to CIDP patients?
So the medications that I discussed are really good for what's known as autoimmune diseases because they're really geared at, um, you know, the immune system and dampening down the immune system's attack on your body.
Yeah,
So it could potentially be useful for other autoimmune diseases, but not necessarily other neuropathies.
understood. And the last question that that I want to raise today before we have to close is about, the flu shots or the COVID shots. Obviously, Bob had a little bit of a bad bout with one of them. Lots of other patients have had similar experience. Dr. Tiongson, do you have any thoughts or further comments to say to a patient who might be a little hesitant about getting another vaccine because of the risk, or similarly, if they thought maybe they did contract it from a vaccine in the past?
Yeah, I mean, that's a tough question because, I mean, CIDP and like other autoimmune conditions is caused by, the immune system getting overactivated.
Yeah,
So, that can occur indeed due to a vaccine. Um, it has been reported in the flu shot. It is more commonly activated in response to infection more so than vaccines. So it's possible that, you had a reaction to the flu shot. You could have also had the same reaction to the actual flu, or the same reaction to COVID, or so it's a challenging question because it can happen in both situations, and it happens more often in response to infection than to vaccines. But um,
yeah,
I guess it's always a risk benefit sort of decision.
understood.
I think that a
Well,
lot of diseases have been better controlled thanks to vaccines. So, I still certainly believe in their use.
okay, great. Thank you so much. Thank you both so very much. We had a lot of questions. I'm so sorry we weren't able to get to all of them, but I feel like we covered a lot during this hour. I thank you both for your time and for your expertise. Obviously for your support of our organization, our educational programs. Thank you to Johnson & Johnson for the support of this program specifically. I do hope that everyone joining today will take our survey at the end of the webinar. It allows us to make sure that we are doing as best as we can, and we're tackling the problems that are faced by the population that we service. And I hope that you consider supporting us at the end of the year as well. We really could use every single dollar to help us support our mission and continue the fight that we're doing. And what's even great, and I'll put the final plug for my fundraising pitch to conclude, is every dollar that is donated through the end of this year will get matched up to $100,000. So now's the time to double your impact. So thank you again both so much. We so appreciate your expertise, and thank you to everyone joining today. We hope that you learned something new. Have a great, happy holiday season, and we'll see you next time. Thank you again.
Thank you.